So welcome to the final grand rounds of the 2025 year. So for today's grand rounds, we're going to hear from your fellow residents. And these are residents who have participated in one of the Mentors of Medicine programs. And while working 70+ hours per week clinically, they've managed to do some research. And they'll be presenting that research today. Our first speaker will be Rosie Quinn. The title of her talk is Development and Validation of a Novel Algorithm to Evaluate Prescription of Mart in Asthma. Dr. Quinn.
All right, good morning. So I'll begin with a little bit of background. Global and national guidelines recommend ICS formoterol inhalers for both maintenance and reliever therapy, also termed Mart, for moderate to severe asthma. This recommendation is based on multiple high-quality randomized controlled trials that Mart reduces the risk of severe asthma exacerbation. There have been many studies demonstrating that adoption of these guidelines has been poor, and here I'm highlighting a study by Zay and colleagues out of Yale. They analyzed asthma encounters at pulmonology and allergy clinics within their health system and determined via manual review of their provider notes and prescription signatures that only 14.5% of patients with moderate to severe asthma were prescribed Mart by their providers. In addition to producing this striking finding, this study left us with the three following impressions. One, the volume of manual reviews required to complete this study was prohibitively labor-intensive, and largely this is because, two, assessment of any efforts aimed at improving these prescribing rates would require a duplicate volume of manual review. And three, if such a substantial implementation gap exists amongst academic specialists, then we wondered what was the state of guideline adoption in primary care or in community settings where the vast majority of asthma care is occurring. As such, we designed a study with two major aims. The first aim was to develop and validate an EMR-based algorithm capable of accurately and efficiently identifying when Mart has been prescribed to an eligible patient. The second aim is to then deploy this algorithm across multiple healthcare systems and settings in order to characterize Mart prescribing practices. The study design is a retrospective cohort, and our methods are outlined here by aim. For the validation aim, we started by training the algorithm by iteratively comparing its results to that of a manual reviewer to identify areas for improvement in the code. The next step will be to perform a blinded manual review in order to determine the prevalence-adjusted, bias-adjusted kappa agreement between the algorithm and manual review. We've chosen this statistical tool due to the unfortunately markedly low prevalence of our outcome of interest, which is Mart prescribing. Once we have demonstrated acceptable agreement, we will then partner with additional study sites in order to deploy the algorithm. Our algorithm works by first identifying encounters with an ICD-10 code for asthma. It then evaluates for moderate to severe asthma based on the presence of an ICS LABA or a medium to high dose ICS inhaler prescribed on the active medication list within the encounter, or if the occurrence of at least 2 asthma exacerbations are present within the prior 12 months to the encounter of interest. We have defined asthma exacerbation by the prescription of a systemic corticosteroid within 7 days of an encounter for asthma, or by the use of the ICD-10 code for asthma exacerbation. If either of those criteria are met, then the algorithm determines that Mart is recommended. If Mart is recommended, the algorithm then determines if the inhaler prescribed is an ICS formoterol or Mart concordant inhaler, and if the prescription signature for the inhaler includes an instruction for as-needed use. We determined that this was the best way to accurately identify Mart prescriptions within the EMR by reviewing over 2,800 unique prescription signatures within our data set that corresponded to a Mart prescription, and then we identified common language. Specific inclusion of PRN or the word needed in the prescription signature allowed us to identify these Mart prescriptions. If both of those criteria were met, then the algorithm designated the encounter as Mart prescribed. Our initial efforts to evaluate agreement between the algorithm and manual review have been promising, with agreement in 98 out of 100 of the initial encounters compared. However, due to the low rate of Mart prescribing, additional manual review has been necessary to refine the algorithm prior to assessing our kappa agreement. The following is some preliminary data based on the application of our algorithm to our healthcare system here at BJC. This figure demonstrates that within our healthcare system, around 2/3 of the asthma encounters analyzed were consistent with moderate to severe asthma, and therefore the patients in these encounters would qualify for Mart. This figure is the most sobering of our preliminary data. Within our healthcare system, only 2.8% of patients with moderate to severe asthma were prescribed Mart. This is obviously a markedly lower rate of prescriptions than that which was identified in the Yale study. Thinking about this, we hypothesize that the difference might be due to both the broader inclusion of practice settings and provider types within our data set. Additionally, our strategy of applying only the use of the prescription signatures in our algorithm rather than the inclusion of provider notes could be contributing to this difference in the rate. At the provider level, we've found that specialists are more likely to prescribe Mart at least once. The value highlighted in yellow represents the percent of primary care providers caring for at least one Mart-eligible patient who prescribed Mart at least one time in our study period. My take-home point for this piece of data is that 75% of primary care providers in our analysis never prescribed Mart. That's not to say that specialists are performing much better than their primary care colleagues, however. In red, I've highlighted that more than half of pulmonologists within our data set with at least one Mart-eligible patient never prescribed Mart either. A perhaps surprising finding at the patient level was that patients with Medicaid were more likely to be prescribed Mart than those with Medicare, private, VA, or military insurance. This finding may be unique to our healthcare system here in Missouri, as Missouri Medicaid does specifically encourage and promote Mart prescribing. To conclude, our algorithm has demonstrated acceptable agreement on initial validation efforts. Our next steps regarding the validation aim will be to determine our prevalence-adjusted, bias-adjusted kappa agreement, and then externally validate the our algorithm performance with a secondary healthcare system. Our major finding, as demonstrated by prior work, is that Mart is dramatically underprescribed. Prescribing rates within our healthcare system were lower than expected compared to prior studies, though we recognize that our results may underestimate Mart due to the factors I had previously mentioned. The promise of our work is really in the next steps for our second aim. The algorithm could be a tremendous tool in efforts to improve Mart prescribing. We hope to maybe design a real-time warning system within our EMR that could be used at the point of care of an asthma patient to better prescribe guideline-directed therapies. and we expect that the algorithm will allow for efficient and accurate evaluation of future implementation and improvement efforts. First and foremost, I'd like to thank my mentors, Dr. Krings, Dr. Hofford, who are here in the audience. I'd also like to thank Dr. Gage, Dr. Eisen, and the rest of the MIM program for providing the funding that allows this work to happen. Thank you very much for your attention.
Rosie, thanks so much for a good talk and the sobering statistics about Mart. We're going to continue in that vein with the talk by Pham entitled The Cost Comparison of Single Maintenance and Reliever Therapy versus Traditional Inhaler Therapy to U.S. Healthcare Payors. Try.
Hey everyone. So, as Rosie mentioned, there is a big implementation gap with Mart in this space. So I use the word SMART in this presentation to kind of lure you in, but SMART has been increasingly referred to as Mart in the asthma space, so I'll be using this term throughout. I have no disclosures. So as a quick background, traditionally, moderate to severe asthma has been managed with 2 inhalers, one for daily maintenance and a different one for symptom relief as needed. Since 2019, however, major guidelines have recommended Mart, a single inhaler approach that combines both functions, replacing the traditional 2-inhaler regimen. Mart uses ICS formoterol, which is both a long and rapid-acting beta agonist. Unfortunately, uptake of Mart remains very poor, and it is estimated that less than 20% of Mart-eligible patients actually receive Mart. While there are many reasons for this, a major one is that many pharmacy benefit managers often do not include ICS formoterols on their preferred drug formularies. So, to inform coverage decisions for payers, we conducted the first US-based cost analysis comparing Mart to traditional therapy from a healthcare payer perspective. We hypothesized that despite the higher inhaler cost, Mart will ultimately be more cost savings and due to less downstream exacerbation expenses. So, to start, we built a probabilistic decision tree model to estimate cost over 1 year. We conducted 50,000 simulations with this model. So, on the left, we begin with the patient, and the first branch splits into the 2 treatment options, Mart at the top and traditional therapy at the bottom. After that, each branch shows the possible events, no severe exacerbations, or one of 3 types of severe exacerbations. And these are the same for both treatment paths. So, to inform the model, we used data from 6 randomized controlled trials, which were identified through a broad, systematic literature search and selected if they reported outcomes of interest and inhaler use. We aggregated the results to estimate how often different types of severe exacerbations will occur, and these numbers are listed as events per person year. Next, we then estimated the mean actuations per day. All puffs were standardized to budesonide formoterol equivalents in the US. So for Mart, they use about 3.3 puffs a day on average, while for traditional it uses about 2.8. And the average albuterol use was about 2.3 puffs daily. For cost, we used national databases. Our primary analysis used the midpoint between the VA federal supply schedule and the national average drug acquisition cost. And to simulate the upper and lower bounds of prices paid by payers, we used the average wholesale as well as the good RX prices. Next, we have exacerbation costs, which is taken from the medical expenditure panel survey. and all prices were inflated to 2024 US dollars. And finally, we looked at QALYs. QALYs basically means quality adjusted life years, and it's a way to assess whether a treatment provides good value for what it costs. One QALY represents 1 year in perfect health, while a value of 0 represents death. So we assume that both treatment groups started at the same baseline QALY, and then each type of asthma exacerbation reduced the QALYs. So it would be 0.1 for oral steroids, 0.15 for ED visits, and then 0.2 for hospitalization. And we assumed patients stayed in this exacerbation state for 2 weeks before returning to their baseline. So to evaluate cost effectiveness, we use a willingness to pay threshold of $100,000 per QALY, which is the commonly accepted threshold within the US. So to our results. So this is a histogram showing the cost differential of all 50,000 simulations. At our primary price point, Mart is less costly in 57% of simulations and saves an average of about $54 per person year. And here we have the annualized cost of each, and just as we hypothesized, while the Mart inhalers are more expensive, they generally led to lower exacerbation costs, which resulted in overall savings on the Mart side. So next, this is a chart which represents the probability of cost savings as a function of budesonide formoterol cost. So here, we have 3 lines for each of the 3 pricing scenarios. And the big takeaway that I want to impart is that as the prices go down, the probability of cost savings go up. So for example, at our main price point right here, like I mentioned, the budesonide formoterol cost is $187, and at that price point, it was 57% cost savings. However, when we reduce the price, the cost savings go up to about 80%. And we picked $120 because that was about $1 per actuation of this budesonide formoterol inhaler. So finally, this last chart here integrates the QALYs into our analysis. And this is a cost effectiveness plot which displays all 50,000 simulations based on the cost and QALY differential. So I want to go through this chart really quickly. Points to the left of that line indicates that Mart provides lower quality of life in these simulations, while points to the right of this line means that Mart provides higher quality of life. And as you can see, in the majority of simulations, Mart provides a higher quality of life. Points above this line means that Mart is more costly, while points below this line means that Mart is less costly. And the pink line represents the willingness to pay threshold, which is set at $100,000 per QALY, as I previously mentioned. So even if a therapy costs more, it is considered cost effective if it delivers enough improvement in quality of life. Essentially, any point below this pink line means that Mart is a more favorable option. In our simulation, that occurred in 67% of simulations. So, what do I want to leave you guys with? Mart is both less costly and more effective. And while this is the first US-based study, international results are similar. However, direct comparisons are challenging due to differences in our healthcare systems. Next, we reported our results in per person year, but considering that over 25 million Americans have asthma, the potential savings across lifetime could be substantial. We also found that cost savings for payers increased as the budesonide formoterol prices decrease, and this is especially relevant now with the recent introduction of generic budesonide formoterol inhalers in the US. And although the effects can be complex, generally the introduction of generics into the marketplace leads to price reductions through increased market competition. Next, in our study, we used a healthcare payer perspective, which only included direct cost and QALYs. There is a broader type of perspective called the societal perspective, which actually accounts for indirect costs, things like absenteeism and missed work or school, and the subsequent lost wages as a result. Using this would have likely shown even greater benefit for Mart, as Mart reduces exacerbations and productivity loss. And indeed, this is what was shown in the international studies as well. So our results are compelling for the economic value of Mart. So we believe that it is beneficial for healthcare payers to expand coverage of Mart, not only from a patient outcomes perspective, but also from a financial perspective. Currently, we are working to disseminate these findings to relevant stakeholders in the community. For example, the Medicaid within Missouri does a relatively decent job at providing coverage for Mart, but there are still deficiencies across other states and nationally as well, too. These are some of the funding sources that made this work possible. And these are some of the people that made this possible. And I want to give a special shout out to one of my mentors, Dr. Crinks.
Kai, thanks so much for a great talk. Our next presentation will be by Sajal Tiwary. I know you worked all night. Thank you for coming here and giving grand rounds today. The title is Geno Evil, Pheno Evil, Identifying Carbapenemase Production in Carbapenemase Resistant Enterobacterales, CRE. Sajal?
Okay. Thanks for coming, everybody, and sticking out to the end as we leave the lungs and go to the gut. So I'm going to go ahead and get started. Do I use this laser pointer here? Okay. So first off, some disclosures, which I have none, although in these times, maybe it would be nice to have some. So that's where we'll start. Just some objectives to kind of line things up. Well, first, a lot of background on this to kind of give some context to the work and how it was defined, looking at carbapenem-resistance among Enterobacterales, which are all gram-negative, it's a little redundant, infections and colonizers in certain patients in India, and how that affects the antibiotics we use to treat those infections, and then diving into the actual research project we had, looking at how we diagnose these pathogens, how we diagnose the production of these carbapenemases in these Enterobacterales and the assays that are employed, and how good they are in certain types of pathogens. So we'll just start off, like I said, with some background as to what we are talking about when we talk about carbapenemases and carbapenem-resistant bugs. So this chart here is put out by the WHO, I'd say every year, every other year, and defines certain critical, high priority pathogens of interest throughout the world. And you can see there's like a critical group, and then there's this high group, medium group. Obviously, we're going to go straight for the money to the critical group here. And you'll see that there are 3 pathogens of interest, or at least groups of pathogens of interest. One is Acinetobacter, carbapenem-resistant Acinetobacter baumannii, or crab. And then these other 2 are both Enterobacterales. One, third-generation cephalosporin resistant, so producers of ESBLs, as you guys are probably familiar with. And then down here in the bottom, the mortifying carbapenem-resistant Enterobacterales, which is the subject of this talk. I'll be calling them CRE for the remainder of the talk. I don't want to sound like Chicken Little too much, but I know ID doctors always seem like they're sounding the alarm on how terrible these things are, and there's a pandemic of resistance, and we need to be good stewards, and it's all true. So I really do encourage you that this chart is put out for a reason. This is truly the silent pandemic, as they say, and stewardship and wise use of antibiotics is of paramount importance, and that's, I think, enough to demonstrate why this work is important. So the CRE, we're going to go down a little bit of a biological rabbit hole, so bear with me. we typically bin them into different groups based on their mechanisms of resistance, of which there are many. So we'll focus on the left side of this tree here. These pathogens are things like Pseudomonas and non-CRE. In the CRE group, we have what are called carbapenemase producers and non-carbapenemase producers. Carbapenemases, as the name suggests, are enzymes that hydrolyze carbapenems. So obviously that's a great way to deter yourself from an attack from a carbapenem if you just destroy it. There are other methods of resistance, things that can reduce concentration of the antibiotic in the organism, things that just efflux it out, changes in the targets, et cetera, et cetera. We won't focus on those. We'll actually just focus on the carbapenemases alone. Because there's actually convincing data that shows that Enterobacterales that have carbapenemases lead to worse clinical outcomes than those that are resistant by other means. Within the carbapenemases, there are several classes, and you guys maybe have heard of like the Ambler class C, heck yes organisms, inducible resistance. That's the more glamorous one. There's actually other classes as well, A, B, C, D. These are all, like I said, carbapenemases that can hydrolyze carbapenems, and they all work mechanistically relatively similar, but structurally they're different, and that in turn affects what antibiotics can be used against them. You can see here on the left, we have a higher propensity of carbapenemases that have been identified with clinical significance. These are serine beta-lactamases. They have a serine group that helps promote the hydrolysis. On the other side, we have metallo-beta-lactamases. These employ usually a divalent cation in order to promote their hydrolytic activity. Even though there's fewer identified enzymes under the metallo-beta-lactamase class, these are actually of critical importance among CRE. These stand for things like the MDM is New Delhi metallo-beta-lactamase, identified in New Delhi. VIM is for Verona, IMP is an imipenemase. So these are all very obvious names, usually derived from where they were first isolated. In terms of the serine beta-lactamases, we have other types of enzymes. OXA is oxacylamases, KPC, the Klebsiella pneumoniae, carbapenemase. This is actually the most prevalent one in North America, but throughout the world it's actually less prevalent. So I just want you guys to kind of keep in mind this distinction between these two types of carbapenemases, and in particular focus on how OXA and NDM are two different types of carbapenemases of two distinct classes, because that's what we studied in our cohort of CRE. Now you're probably thinking, okay, why does this matter? You're just doing a lot of cool grand rounds, basic science mumbo jumbo. There's actually, has direct clinical impact because oftentimes the carbapenemase that's present dictates what antibiotic can be employed in the infection. I won't go through every single row and every single detail here. Suffice it to say, you can see that these are all pretty novel beta-lactam, beta-lactamase inhibitor combination therapeutics on the left. Things that I've mostly seen in my time as a resident here, employed in the ICU with very debilitating infections, folks with chronic infections, and there's actually variable susceptibilities depending on the carbapenemase itself that's present. And we do have agents that are, of course, that can address any carbapenemase, but as I said before, we should be good stewards of antibiotics, and if we can tailor our therapies, then we should to kind of keep this crisis from accelerating. So that's kind of the general context for what we're talking about with CRE and carbapenemases and why they're important. For the next part, we're going to talk about how we identify them, and this is where things get quite interesting, and there's a lot more details, so please, if something's confusing, just raise your hand, shout out, it's fine, I can repeat myself. So the assays that we use to detect carbapenemases are actually pretty wide and far varying, but there's two general groups. One is for genotyping and the other is for phenotyping. So genoeval, phenoeval. For the genotyping assays, these essentially rely on the use of a PCR-based assay with probes against the genes of interest, i.e. here carbapenemase genes, to detect whether or not that gene is present in the organism of interest. Obviously, this requires a PCR machine, someone who knows how to work it, there can be a lot of expenditures involved, and you have to have a specific probe for every carbapenemase. So if you have several carbapenemases that are prevalent in your area of practice, or if they're novel carbapenemase, they wouldn't necessarily be detected. And the other thing more biologically important is that just because you have a gene doesn't mean it's expressing a carbapenemase. That central dogma has long withered away, and you can't necessarily one-to-one extrapolate that from just having a gene. So those are some of the pitfalls of these assays. But they're very, very sensitive and specific and obviously give you a lot of information. On the flip side, there are phenotypic assays which essentially determine whether or not there's resistance of these organisms based on the most downstream thing you can monitor with bacteria, which is growth, essentially. So these are typically growth-based agar assays. They're quite cheap. Any technician can usually work with them. They use one or two tweaks in the way that the growth is actually conducted on the plate in order to determine if there's a carbapenemase being produced. But it is not as granular and informative as a genotyping assay because it doesn't give you the specific gene and subtype of a carbapenemase. It only tells you whether or not there's resistance, essentially. And this can get more complicated because, as I mentioned before, there's actually many ways these bugs are resistant, not just carbapenemases. So that could confound the results in these growth-based assays later on. So what we end up doing, and what we do here at Barnes actually, is both. We do both genotyping assays and phenotyping assays before we commit a certain isolate to being a producer of a certain carbapenemase. And as you can imagine, that is kind of lengthy and exhausting. The assay that is in use here and in many places across the world is called the MSIM and the eSIM assays. The CIM stands for Carbapenem Inactivation Method. And it's actually very glamorous and creative, and I could not help myself but show you guys how it works. So we'll start with this tube on the left here. This is the MSIM. The M stands for modified. What this essentially boils down to is this M is a disc of meropenem that is incubated in a broth containing the pathogen isolated from your patient. So this sits here in the tube for about 4 hours, and then the disc is removed, and it's plated on agar that is coated with a known susceptible strain of a test bug, like an E. coli. And then you monitor for growth. If you have a big zone of inhibition in this test, that means that the meropenem is both there and active. So whatever was incubated in previously did not inactivate, carbapenem is activating, did not inactivate the meropenem, i.e. there is no carbapenemase in there to begin with. If, however, you don't have a zone of inhibition around there and the test strain just grows normally, that means this meropenem has been essentially disabled by whatever was in this broth before, which would be the carbapenemase here. And that's the MSIM component of this. So this tells you whether or not there's a carbapenemase specifically produced by that organism. To take it a step further, to determine the broad subtype of carbapenemase, we perform the eSIM. The E here stands for EDTA. So it's the exact same process as the MSIM with the exception of the initial step. There's incubation of the meropenem disc with EDTA, which is a chelator of divalent cations, which, if you recall, is what's required for the metallo-beta-lactamases to work. So the exact same thing is carried out, and you look at growth here. In this case, if there is growth all around the meropenem, that means this meropenem was inactivated by the bug in here, despite the EDTA's presence. So that means that whatever enzyme is in here with this meropenem disc, it doesn't need divalent cations, i.e. it's not a metallo-beta-lactamase, it's a serine carbapenemase, serine beta-lactamase. If, however, there is inhibition, that means that this was inactivated, so it was a metallo-beta-lactamase in there. And that's how you can distinguish a metallo-beta-lactamase from a serine-based carbapenemase, which is, as I said, that's kind of the big decision point, big branch point for which antibiotic you have to select to treat the organism. These assays have some cutoffs that have been designated by the initial creation of the protocol years ago, and they've been very well validated in isolates that have one carbapenemase, be it a metallo-beta-lactamase, be it a serine carbapenemase. There's actually excellent sensitivity and specificity for the MSIM. The eSIM is not as sensitive, but it's quite specific for the metallo-beta-lactamase production. And this is what's used, as I said, here at Barnes, too. Just some pictorial representations of these results. So again, just to reiterate, if there's no zone of inhibition around the MSIM, that means the carbapenemase was produced, and this is just a dummy disc. There's no meropenem in there anymore. And then if you do the eSIM and there's a zone of inhibition all of a sudden, that means that this is a metallo-beta-lactamase. So in our case, like an NDM, for example. However, if there is a small zone or no zone around the MSIM, that means there's a carbapenemase, and then there's no change in the eSIM, so it's about the same zones here, that means that the eSIM was negative, which means that that isn't a metallo-beta-lactamase, it's a serine-based carbapenemase. So in our case, an oxa carbapenemase. So that was a lot of words, I'm sorry, but hopefully that's somewhat clear as mud. So we'll jump into our study, which is to essentially analyze these assays in the context of isolates taken from a cohort of patients in India where they have a host of carbapenemases. And in particular, we are interested in isolates that have multiple carbapenemases to each species, not just one or the other. This is an evolving group of pathogens that we're seeing as more and more of these broad spectrum antibiotics are being used, resulting in, as I said, multiple carbapenemases within the same isolate. We hypothesized that the MSIM and eSIM would still say that there was a carbapenemase being produced, but it wouldn't be able to distinguish whether or not it was a metallo-beta-lactamase or a serine carbapenemase by virtue of the fact that both of them are present in the isolate. And this is just a phenotype-based assay, so it wouldn't be able to necessarily distinguish those. So, this is our data. this is the meat of the talk here. Oh, it's a little grainy, I'm sorry about that. So as I said, these are taken from patients, these are isolates taken from patients in India. These are perirectal swabs, only looking for colonization. So these are not actually infectious like cultures. This is just a colonization-based culture. This is the breakdown by species, mostly Klebsiella and E. coli, which is the more predominant CRE anyways across the world. So this is kind of as we expected. And these are our results for the MSIM and the eSIM. So we'll start with the MSIM panel here. So down here, we stratified the isolates based on the results on their genotyping assays. So if the NDM isolates here, for example, had the NDM gene on genetic testing. Here, they had the oxygene, and here they had both present. Now, as I said before, that doesn't necessarily mean that they're producing them, it just means that they had the genes. Here we have the zone diameter for the MSIM test. And if you recall, for MSIM, the smaller the zone of inhibition, the more likely it is that there's production of a carbapenemase. So we'll start with the NDM. Almost all isolates had a very small zone of inhibition, very clearly producing carbapenemases. This red line here is the cutoff for a negative MSIM test. Everything was positive. Same for those that had both NDM and OXA, with the exception of 1 or 2 isolates. However, there was a high percentage, about 50% of the OXA isolates that actually tested negative on MSIM, and they were otherwise positive on this test. So these isolates here were excluded from the eSIM because on the MSIM it looked like they didn't even make a carbapenemase, even though they had the gene. So now we'll move over to the eSIM here. The purple line here demonstrates the cutoff for a positive eSIM result. Anything above this means that it's a positive eSIM result, which means that it has a metallo-beta-lactamase, like an NDM. So again, we're stratified by the genes that we found within each of the isolates. And for NDM, lots of positives, very good sensitivity, with just only 1 missed. But this is actually much higher than what has been seen in previous studies. And same for the NDM and OXA, surprisingly. Very good, robust identification of NDM production. However, there was also erroneous identification of NDM production in OXA, even though they had no NDM genes. And that is kind of different from what we're seeing in the literature, that this is a very specific and less sensitive assay. That was quite a pretty surprising finding. Nonetheless, our focus was on those that had both NDM and OXA, and we see robust, almost 100% true positive rate for identification of production of metallo-beta-lactamase. So to kind of bring all that together in big picture terms, like I said, we were looking specifically at the efficacy of these assays in determining whether or not there's a metallo-beta-lactamase in those that had multiple carbapenemase genes present of multiple different classes. And we had no idea how this would perform. Like I said, the assays have only been validated in those that have one or the other. And in our case, it seems that we have the assay overestimates the production of metallo-beta-lactamases and doesn't really behave differently between isolates that have just one carbapenemase or multiple carbapenemases. There was a little bit, you might have noticed, there were some asterisks. There was a little bit of a difference between those single carbapenemase groups versus the dual carbapenemase groups. It's not a big difference, but perhaps this suggests that we could use the assay with updated cutoffs or updated criteria to help determine what group is what. But that would require a whole other set of validation studies. And I think ultimately the bigger takeaway from this is that this is going to be a very difficult arms race for us to be able to reliably diagnose the presence of carbapenemases or resistance mechanisms in general using the same assay over and over again as these bacteria are evolving. Because as they evolve, our tests will unfortunately also have to evolve. And I don't think there will be much of a way around our current modular workflow of looking at susceptibilities and genotyping and phenotyping all in concert together. There are many other assays being developed now, but ultimately the ones that are actually taking off in the market are those that kind of lump them all into one machine. So just some big take-home points from all that I've said, which has been a lot. I just want you guys to recognize that CRE is a global health threat. It's very important, it's pressing, and it's here in the US as well. And it often is mediated by production of these carbapenemase enzymes, which have worse clinical outcomes than other mechanisms of resistance. And the assays that we use to help identify production of carbapenemases typically only look at those that have one isolate or one carbapenemase or the other, not those that have multiple carbapenemases, which is a growing group of pathogens. And in our study, at least, we found that the sensitivity of these assays is quite robust still, even in those that have multiple carbapenemases, but the specificity is declining. And this points to the fact that we just need multimodal assays probably for the foreseeable future as these pathogens continue to evolve and adapt to the agents that we're using for them. Quick thanks to everyone who helped work on this project. There's our team of scientists over in India at the Kochi Hospital who did a lot of the phenotyping assays, the Dantas lab here at WashU doing a lot of the genotyping and genomic studies. Dr. Growler, my mentor, and everyone in the ID department here has been very supportive. And with that, I will close. There you go.
So I'm going to ask all the ground round speakers to come up to answer questions. And I'd also like to announce the winners of the poster competition. So we had the Mentors in Medicine Symposium last Wednesday, and if you were there, you know there were 26 outstanding posters, and those posters got evaluated, and I'd like to announce the winners of the competition. So there was a tie for second prize for the posters. Brian Zenger for his poster titled Stereoarrhythmia Radiotherapy Prolongs Effective Refractory Period and Increases Ventricular Tachycardia Cycle Without Short-Term Scar Formation. Also in second place was Shannon Coombs. The title of Shannon's poster was The Path to Inclusivity, Aligning Ally Actions with Black Gastroenterologists' Needs. And finally, the winner of the poster competition was Harrison Lancaster for his poster entitled Comparison of Sotalol and Ofetilide for Antiarrhythmic Drug Loading in Patients with Atrial Fibrillation. So a hand for the poster winners. I would like to acknowledge the support for Mentors in Medicine from a number of benefactors, including the Schwartz Foundation, which recently made a donation in honor of Dr. Bowen. And now we have time for question and answer for our speakers. So questions for our speakers. Yes, Dr. Frazier.
Those were all really great talks. So to start with the Mart questions and the Mart and SMART and our underutilization of guideline therapy, do you both have ideas about what are the next steps to try to more rapidly implement guideline therapy? You should both weigh in or individually.
I think it probably comes down to what both of us are working on is both kind of dissemination of knowledge of the updated guidelines, in addition to creating and advocating for a payment structure that incentivizes the application of those guidelines, because we know that they improve outcomes tremendously for patients with asthma compared to kind of traditional therapy with multi-inhaler regimens. And so I think it would take both of those things in order to improve how we're doing with asthma patients.
Yeah, and to build upon that as well, too, we have to assess the financial barriers that exist currently, but also the kind of the patient and provider barriers as well, too. I think part of our studies is kind of eliciting what are the qualitative barriers to prescribing Mart as well, and kind of, pushing back on some of the myths that may permeate the space, and maybe try to push back against some of the resistance to prescribing Mart beyond just the pay incentives and the structure.
Rosie, can you comment on the feasibility of a BPA in EPIC for alerting providers who are caring for patients with asthma?
I hope to be able to comment on the feasibility. I think what we're finding is that it is certainly possible to evaluate these things real time. And our next step would be to assess the feasibility of a BPA. That's certainly the goal, to try and improve asthma management here within our system and beyond.
Other questions? Yeah.
For the looking at antibiotic-resistant genes, do you know if looking at RNA expression correlate with functional resistance versus like your DNA PCR test? If that could be another way you could maybe do a more high-throughput way of looking at whether these bacteria are resistant?
Sure, yeah. Yeah, so the question was, can you do RNA omics as well? And yes, if you want to give me money to do that, I'd happily take it. But yeah, the way to bridge all this would be to do multi-omics within each pathogen alone, and then be able to see if this is actually correlating with expression of the genes, because there's a hypothesis, and I don't want to get too much into this, there's a hypothesis that eventually maybe bacteria will run out of ways to be resistant and run out of these enzymes to produce just because it's metabolically too taxing. So there could be certain operons that are on or off based on metabolic signatures, and we could potentially identify those through multi-omics. So that's definitely something that would be very exciting. Yeah.
This is for Dr. Pham. I think your cost analysis was very convincing, and because you mentioned that these studies were done in Europe, I'm sure that Kaiser and other large medical systems has looked at that. Is there any inkling that they want to pay for that so that they can decrease their costs in the long run?
I think it's exceedingly difficult to predict what these payers are thinking and what they're prioritizing. I think from our standpoint, I think we can only put out the data that we have created and looked into to kind of create a sort of incentive for them to increase the coverage of these inhalers. But I think your guess is as good as mine, and it's a very unsatisfactory answer. But the hope is yes, they'll eventually, our work hopefully will be disseminated pretty soon. And so hopefully as this makes more, I guess, national recognition, payers will start to look at this and consider expanding their coverage.
So I have a question about the inhalers for asthma. When you have the combined SMART, single maintenance and reliever treatment, which had been Symbicort, and within the last 2 years, the generic is out for the budesonide formoterol combination. There are very few companies that make combination inhalers because you have patents on each drug and you have patents on the inhaler device that functions. I think one thing is that there are a limited number of companies, there's limited competition, and the price has not dropped significantly from the brand name to the generic. So I think that we all know that this is an issue, but there's a problem with the translation into getting a less expensive medication. And I think one of the other problems is that patients in the old days, they were given a prescription for a reliever and a prescription for a controller. And what happens is they would look at the price of both of them, and the reliever was cheaper, and the reliever, they could see and feel that it worked faster. So there's an ingrained thing in patients' minds and in families and in providers that the patients prefer what's cheap and works quickly. Comments?
Yeah, I think that's kind of one of the myths that I was kind of alluding to earlier. There's beyond the financial barriers, there's also patient and provider barriers in terms of, and I've seen this myself, where people say that, oh, my traditional regimen works, I have my controller and I have my reliever, why would I want to change that as well too? And I think that's something that's more nuanced than I'm able to speak on. But I think part of the work we do in the Krings lab is trying to dig deep beyond those things and see what we can do to kind of readdress and re-educate both the patient and providers in the best possible way. I think to your point about the reduction of prices with the introduction of generics, I think Brena, which is the generic version of Symbicort, I think was released, 2 years ago, like you mentioned. I think based on the literature that I've looked at, a lot of times the changes in the market value of these drugs will take some time to occur. I think I've seen up to like 5 years for historical generics, obviously. And again, with the ever volatile nature of the marketplace nowadays, the changes might take longer to come into fruition. but I'm cautiously optimistic that the prices will continue to decrease. And I think even with my time with this project, I was trolling the internet to see what the historical prices were of budesonide, and I think there have been some reductions already just in the past year that I've been working on this project.
So I want to thank all the speakers for wonderful grand rounds today, and for many of you who participated in the Mentors in Medicine program. And I'll ask those that have individual questions to come on up. And also, if your mentors are here, if they don't mind coming down so we can take a photo. Thanks very much.